Hi, hello everybody. Today I would like to talk on topic transporting critically ill patient. So the objective of this lecture is to discuss the principle necessary for the safe transfer and retrieval of critically ill patients and describe the systematic ACCEPT approach for managing such patients. And the key point is transport is a potential period of instability. So, a critically ill patient is defined as a patient who has a critical illness or injury that acutely impairs one or more vital organ systems. So, the adverse physiological changes during transport of the critically ill patients are common and can be life-threatening. So, the decision to transport a critically ill patient is made when potential benefits of transport outweigh the potential risks. So risks incurred during transport can be minimized by careful planning and the use of competently trained personnel and have proper monitoring equipment. So we need to answer this question, why the need to transfer? So actually to reduce in number of and increase pressure on hospital beds, transfer for tertiary care, example neurosurgery, cardiothoracic surgery, and the need for intensive care treatment, either supra-specialist care or because of local shortage of bed. It is important to remember that transfer distance is irrelevant to the need for meticulous preparation before transfer. So the most commonly reported adverse events, cardiovascular problem during transfer is tachyarrhythmias, bradycardias, hypotension, and hypertension. So the other most commonly reported adverse event is hospital equipment problems, monitor, pump failure, equipment not available, mechanical ventilator not available, significant hypoxemia, ambulance breakdown, loss en route, patient having cardiac arrest in ambulance, and deaths during transfer. Bear in mind that movement from one ward to another is just as important and can be associated with just as many problems as a transfer over 500 miles. So, what's the dangers of transporting critically ill patient? So, it can be because of physiological changes during transport, which is came from respiratory system, which is decreased oxygenation, cardiovascular system, where we can have the changes in heart rate, blood pressure drop, and at the same time having neuro issues such as increased intracranial pressure, at the same time having limited resources, equipment problem, technical problem, failure of continuation of care, and crisis of hypo or hypertension with arrhythmias and desaturation. We have three types of transfer critically ill patient, where it can come from pre-hospital on-site to emergency department. Second, the inter-hospital district hospital to tertiary center, and vice versa. And from intra-hospital emergency department to radiology department to operation theatre or intensive care unit or to the ward. This picture shows the challenges that the physician need to deal with, which is need to continue the ventilation, at the same time to continue the inotropic support, the invasive and non-invasive blood pressure monitoring, and other things which critically ill patient need during transfer. So the aim of a safe transfer policy is to ensure that there is continuing medical treatment for the patient without any detrimental effect. So to achieve this, so the right patient need to be taken at the right time by the right people to the right place by the right form of transport. So we need to have the systematic approach to patient transfer. So this mnemonic ACCEPT is very helpful. So A stands for assess the situation, C control the situation, another C is communication, E evaluate the need for transfer, P package and prepare, and T transportation. So for initial assessment of the patient and situation as a whole, so decision to transfer must be made by a senior doctor, preferably specialist or consultant in charge of the patient after weighing the risks and the benefits. So the indications, the benefits must be outweighed risks, and patient need to be stabilized before transport, and anticipation of problems likely encountered en route, and the degree of urgency to transfer. So most of the time, the initial clinician involved with the patient management does not always accompany the patient during transfer. So whoever taking over the patient need to have these assessment questions. So they need to ask, what are the patient's basic details? What is the problem? What has been done to the patient? What was the effect of the treatment given? And what is needed now? And what risks to be anticipated during transfer? The complication will be prevented or reduced by ongoing treatment and monitoring. So there are three major principles. First, do no further harm. Second, ensure the ABCDE are maintained during transport. Third, the most important assessment is the reassessment. To see, control the situation. So the chain of responsibility must be clear throughout the transport, and the most qualified medical practitioner should be responsible for the transfer process. This comprise identify the team leader, identify the tasks to be done, and allocate the tasks properly. So next is the communication. Whoever managing the transport process need to communicate with the patient's consultant, or your consultant if different from patient's consultant. Also need to communicate with the intensive care unit consultant where appropriate. Also talk to the accepting consultant, ambulance controller, and special transportation controls when appropriate. Next is to evaluate the need for transfer. The clinician has to triage the patient considering their priority and decide the urgency of transfer and the nature of medical support required. Somehow we need to ask this question, is the transport necessary? So we look at this diagram. So we ask this question, transport required to optimize patient outcome? If the answer is no, so patient shouldn't be transported. If answer is yes, and we ask next question, can test or procedure be performed at the bedside? If yes, then no need to transport. If no, then you need to ask another question. Benefits of transport outweigh the risks. If yes, then proceed with transport. If no, then patient shouldn't be transported. We also need to ask this question, is the patient stable to transfer? So especially patient with refractory or severe shock, with high vasopressor or inotropic support, patient with risk of hypotensive episode, patient with risk of hypoxemia, where the patient is already on high ventilator settings with FiO2 of 1%, 100%, sorry, and type of portable ventilator available or not, risk of hypoxia, and the secure airway when in doubt, where the patient is having borderline indication for intubation. So for patient who need to have this critically ill transport, just intubate the patient. Regarding the communications must be reliable and available at all times. The communication loop must be established among referring facility, the transport team, and the receiving facility. So the communication between this referring facility and receiving facility should include the following: patient's current condition and management, and the steps needed to be taken in planning and preparation for the transport. So next is the preparation, packaging, and personnel. To avoid complications during any journey, meticulous resuscitation and stabilization should be done before transfer. The preparation principle number 1, stabilize the patient. Second, obtain and check all equipment. Thirdly, fully prepare the transport personnel. So during preparation and package, so need to provide sufficient supplies of drugs, fluids, and oxygen to cope with any extra delays during the transport, and make sure to secure the tubes and the lines. So the transport personnel also need to prepare basic monitoring equipment such as pulse oximetry, suction, electrocardiography, defibrillator, blood pressure, thermometer, urinary catheter, naso or orogastric tube. And if patient on chest drain, so the chest drain should be secured and unclamped with any underwater attachment replaced by a Portex drainage bag if available. For equipment handling during transport, all equipment should be adequately restrained and readily available to the operator. Monitoring and efficient devices should be kept in areas visible to the accompanying staff. And patient stretchers should be adequately secured within the transport vehicle to prevent injury to patient whenever the driver pressing an emergency brake. So the transfer team should confirm that all equipment is functioning, including battery charge status and oxygen availability. So whoever in charge transporting critical patients who need oxygen support, they need to know the cylinder size they're going to use during transfer and need to do some oxygen reserve calculation. So most commonly used for short distance transfer is type C, D or E, and sometimes size M4 and M6. For type D, contain 350 liter oxygen with cylinder constant or tank factor of 0.16. For type E, so it's about 625 liters with constant with tank factor of 0.28. So this slide shows how to calculate the duration for the given oxygen in specific tank. Total oxygen in the tank equal to PSI minus 200 PSI. So PSI stand for pound per square inch, or more precisely pound force per square inch. Then we need to time the PSI with the tank factor, then you get oxygen in liter. Next, for the duration of oxygen equal to total oxygen in the tank in liter, divide by flow rate given to patient, such as patient on nasal prong 3 liter per minute. So if using tank D, so the 288 liter divided by 3 liter per minute, so equal to 96 per minute. So now remember the formula. Duration of flow is PSI times tank factor divided by time. For example, just now 2000 PSI minus 200 PSI times 0.16 for tank factor tank D divided by 3 liter per minute flow oxygen on nasal prong, so equals to 96 minutes. So if transport time from the district hospital to the destination hospital is about 2-hour journey, and patient is using face mask 5 liter per minute, so how many tank D oxygen should be prepared? So from this formula, we see 2000 minus 200 PSI times 0.16 divided by 5 liter per minute equals to 57.6 minutes. So for 2 hours duration is about 120 minutes. So we divide into 57.6 minutes and we manage to estimate the tank needed is 210. According to the Ministry of Health guidelines on transporting critically ill patients, the personnel need is about minimum 2, which excluding driver, ambulance driver, and the one who attended should be an experienced medical practitioner who is competent in resuscitation and organ support. So the minimum medical officers are required to accompany critically ill patient. The medical personnel should also bring the certain equipment such as phone, need to bring inquiry number and name, the revenue, the safe clothing, organized route, some nutrition, and don't forget the leave home, where to ensure all equipments to be returned back to base hospital. Medical personnel who involved with the transport critically ill patient also need to do some handover, which they can use mnemonic clear, CLEAR. So C for stand for case notes, which they need to bring all the case notes of the patient together with the laboratory findings, the evaluation from the referring doctors, the audit form if available, and the checklist of the return equipment if available. So next is T, transportation. So factors involved with transportation is first, nature of illness, the urgency of transfer, need to decide when is the mobilization time, and also any geographical factors involved, the weather, the traffic conditions, and the cost of the transportation process. So during transport, need to have a constant direct observation of patient by medical personnel. And this direct observation should be supplemented by vital sign monitoring that include the following, which is continuous rhythm monitoring, cardiac rhythm monitoring, non-invasive blood pressure, heart rate, respiratory rate, oxygen saturation, and the CO2, which recommended especially for transporting intubated patient with head injury or raised intracranial pressure, which because it can be detected early compared to other parameter. And the documentation of monitoring is recommended at 15 minutes interval or shorter whenever clinically appropriate. And bear in mind that alarm should be visible as well as audible in view of extraneous noise level during the transport process. So now we go for the case discussion. This case from Hospital Treatment. A 27-year-old mechanic presented with headache. A clinical diagnosis of subarachnoid hemorrhage is confirmed by CT scan. The local neurological center is about 70 km away by road, and the patient vital signs are airway is pattern with FiO2 of 85%, and breathing rate of 14 per minute with no focal sign, and from circulation, sinus tachycardia about 110 per minute with blood pressure of 120/70, where the IV access secured. And the disability, the GCS is full 15/15 with pupil reactive to light with no lateralizing signs with glucose of 7 millimole per liter. So elaborate an outline of how you as the doctor in charge will arrange this patient's transfer to the neurological center. So we follow the ACCEPT approach, ACCEPT approach. So this patient, male, 27 years old. So what is the problem with this patient? So diagnosis, subarachnoid hemorrhage. So what has been done to this patient? So the doctor intern already start the, what we call that, cerebral protection, prevention of secondary brain injury, CT scan and lumbar puncture done. And what was the effect? So for the time being, maintaining the status quo and preventing secondary brain injury. So what is needed now? So need to transfer for further assessment. And there are potential problems that may arise during transfer, which is patient might having airway obstruction or hypoxemia. For breathing, patient might having hypocarbia, respiratory arrest, or for circulation, patient might having cardiac arrest, dysrhythmias, hypoglycemia, and hyponatremia. And for disability, patient might deteriorate in GCS, might also having fit or extension of subarachnoid hemorrhage and development of raised intracranial pressure. So next is C, control. A comprehensive assessment by the clinician in charge, and the decision has been made to transfer the patient to hospital for further investigation. For the next C, communication. So the communication had been done with consultant, the intensive care consultant, patient's relative, and the accepting consultant and the ambulance controller. So next is evaluation. The need for specialist care has already been determined as part of the clinical assessment. And for P, so prepare and packaging. The patient has been stabilized before transfer. All baseline blood tests, including arterial gases, has been requested, reviewed, and appropriate action taken. And all the relevant equipment monitoring and treatment has been prepacked and checked with contingency equipment that should be required in case the patient deteriorates, also prepared. So next is the personnel, the ambulance crew, one doctor, one nurse. Shortly before transfer, all the patient's documentations has been photocopied and appropriate forms are available to record the patient's condition during transfer. So this slide show the challenges in managing and transporting critically care patient. So the person who transporting the patient need to have the in-depth understanding of the physiology of the disease of the patient, and they also need to have skill in delivery of advanced intervention. They also have undergone the specific training for critical care management patient, and also as well as they have this effective communication skill. They also have this team dynamic or team working, and they are very effective in managing a critical care patient in chaotic environment. So for take-home message, so the necessity and safety for transport should be assessed by a multidisciplinary team. Risk of transport should be weighed against potential benefit, and the use appropriate equipment, personnel, and planning for each transport can minimize these complications and ensure optimal benefit to patient. And remember to wear PPE during transportation. And for critical illness, because of critical illness is common, so need to identify early, resource and monitor appropriately, and simple treatment can make a big difference to the outcome of the patient. So this is the guideline from Ministry of Health on transporting critically ill patient that we use as part of our reference. So thank you very much. Any question?